of today's talk are, first is to discuss the principles of prescription in drugs during pregnancy and lactation, and second, what are the physiological changes which are occurring in pregnancy that affects the pharmacodynamics and pharmacokinetics in mother. And most important is this is a common short note or full question comes, a definition of teratogen and least important teratogenic drugs with their teratogenicity. So I would, in short, I will be discussing this also. And as Dr. Ashwat Kumar was telling, uh, speaking about the drugs, entire drugs I cannot cover in one single session. So what I have done is, at the last I have given my mail ID. So you can enter, you can send me the questions on that mail ID. I would love to answer. And shortly, we from Foxy, I intend to bring one drug directory, which is very relevant and apt, so that you can, from that drug directory, you can definitely know what are the effects, side effects, contraindications as a ready reckoner. So these are my intentions for today's talk. As I want to tell you one thing is, what is rational drug therapy? So whenever we are talking about rational drug therapy, that means using the right drug in right dose and for the right duration. This should be always intention whenever you are prescribing any drug. Okay, so these decisions, whenever you are prescribing in pregnancy, they are individualized and they involve complex maternal, fetal, and infant risk benefit consideration. So you should have, whenever you are prescribing or choosing a drug, you should have a proper information, the dosage system, the kinetics, dynamics, and pharmacovigilance. All these things are very, very important. And the gestational age at which you are prescribing. So whenever you are taking history and writing any prescription in that matter, in any woman, you always should ask her last menstrual period. So inadvertently, many prescriptions are given without asking LMP, and so that first trimester, many of them, and they take over the counter drugs, and there are many things they happen, many teratogens, teratogenic effects can occur. Second one is safety of the drugs, and third is the effect on the lactation. So if you see the medication used during pregnancy, it is on increase. For example, if you see this 4 or more medication at any time during pregnancy, it is also on increase. And even on the first trimester, if you see here, the curve is going on. So people are approaching many doctors, multiple polypharmacies there. So there is an interesting study I came across, that what is a drug utilization pattern during pregnancy. So it was seen that the folic acid was taken, which is very important, less than 50% of the woman, which we always prescribe this folic acid periconceptionally. And 1% of this woman, pregnant woman, they consumed category X drugs inadvertently. 15% consumed category C drug. And we all know that various Ayurvedic drugs, homeopathic drugs, the content of which we don't know what it is. Many of it contains lead and very harmful substances, but people inadvertently they take these drugs. So they found that in this study that 11% in first and 2% in second and third trimester. So there is always a need to educate and counsel women of childbearing age regarding the advantages, disadvantages of this drug used during pregnancy, with special reference to alternative therapies and self-medication. So pregnancy, why it is important is we have to know about the physiological changes what they occur, and definitely these physiological changes are for the fetal growth. Then there is alteration of there is, of course, this physiology also causes the alteration of the pharmacokinetics of the drug. So let us go, what is maternal, what happens in the mother's physiology. There is in change in the body fluid volume, changes in the cardiovascular parameters and pulmonary function, alteration in the gastric activity. There are changes which are very important, that in serum binding protein concentration and occupancy, alteration in kidney function. So if you see the gastrointestinal motility, it is decreased, but there is no major effect on the drug absorption. Because of this less reduced gastric emptying, there is a delayed appearance in the plasma. So orally administered drugs, especially during labor, they appear in the plasma late. This is very important thing you should know. And second is, when you are giving injections in intramuscular site, the tissue perfusion is increased because of vasodilatation. So they might be effective in these movement. If you see the distribution of total body water or plasma, it increases to there is a hemodilution, there is huge hemodilution. So the plasma albumin is declines by some 10 gram per liter. So there is scope for the increased free concentration of drug that is bound to albumin. This is very important whenever you are prescribing, because there is an unbound drug which is free to distribute and it is metabolized and excreted. So, for example, concentration of phenytoin is unaltered, although the total plasma concentration is reduced. So, this is very important to study. If you see, the hepatic metabolism is also at increase, but not the blood flow to the liver. So, there is increased clearance of drugs like phenytoin and theophylline. So, this elimination rate again depends on the liver enzyme activity. The drugs which are rapidly metabolized, their elimination rate depends on their delivery to the liver. For example, if you see the hepatic blood flow, they have unaltered clearance like pethidine. So we should take into account this one also. And third one, very important, is the elimination through the kidneys. The renal plasma flow is almost double. So there is a rapid loss of drugs. They say that whenever you are giving amoxicillin, you should increase the dose whenever you are treating systemic infections. But for if you are giving amoxicillin for urinary tract infections, it is mainly concentrated in the urine. So you need not increase the dose. So this is how, in a nutshell, you remember this, that these are the parameters and these are the consequences. So this slide, you remember that these are the physiological changes and these are the consequences whenever you are prescribing this one. The second one is the placental pharmacokinetics. Uh, as there is a as the gestation increases, there is increase in the blood flow through the placenta also. There is a transfer of flow, limited drug which is affected by the placental flow. And this is always a size dependent transfer. And we always should know about the placental metabolism like dealkylation, hydroxylation, dimethylation, which affect the drug transfer across the placenta. At term, you know that the surface area of the placenta is at maximum and nearly all substance can reach fetus. We know that thalidomide has reached through the placenta. And these are the various factors which are affecting the placental drug transfer and fetal tissue. The rate at which the drug crosses the placenta and the amount of drug which is reaching the fetus, it always depends on the duration of exposure of the drug, distribution characteristics in different fetal tissue, and the stage of the placental and fetal development at the time of exposure of the drugs, and all effects of drugs used in combination. And most of the drugs, there is no something we always think of placental barrier, but it all depends on the drug's molecular weight. And if the drug's molecular weight is below 1000 daltons, it easily crosses the placenta. The main determinants of this drug concentration in the embryo are the other factors also they count, like lipids solubility, protein binding, degree of ionization at physiological pH, and the placental blood flow and surface area which is available for the transfer. So we also we know that these are the categories we used to use earlier. So we always categorize like category A. The safety has been established using human studies. There are no fetal risk. Category B, presumed safety based on animal studies, but no well-controlled human studies. Category C is uncertain safety. The animal studies show an adverse effect, but there are no human studies available. Category D, where evidence of fetal risk, but benefit outweighs the risk. And category X is highly unsafe. risk outweighs any possible benefit. This classification applies only to the therapeutic dosages of the drugs and not to the overdose. So this is a simple classification, but what are the fallacies? So there is a new pregnancy and lactation labeling rule which has come into picture on 30th June 2015, which has three principal components. One is a risk summary, second is clinical consideration section, and third is data section. There will also be a new subsection called as female and males of reproductive potential. So you can see here, this is a prescription drug labeling section. So 8.1 is pregnancy, 8.2 labor and delivery, and 8.3 is nursing mother. In this 8.3, they have also added females and males of reproductive potential. So this is now the new labeling system yet to exist. I have not seen any bottle or anything written 8.1, 8.2, 8.3. We still have that in our mind, A, B, C, D, X, whatever is established long ago in 1977. So what are the studies which are focusing on the risk? It is highly unlikely that we conduct any RCTs in pregnant women to study the drugs. And these observational studies are used, and all the models have their own limitations. Secondly, what we know is only the case reports. Like we have the case reports of thalidomide or isotretinoin. These are the only case reports we have. There are some case series. There is no comparison group to examine the variables. So we cannot compare the drug effect in one group and other group, and we should have the comparison. There are no prospective comparative cohort studies, only few, often conducted by teratology information services or case control studies which are retrospective. There are meta-analysis. These are the things which we come to know whenever we are studying any drug effect in a pregnancy. So we should have an administrative database increasingly used in research and more frequently to conduct post-marketing surveillance. So one should have the national birth registries, and we can conclude that this drug has some effects and some side effects and some effects on the fetus which has caused teratogenicity. So always think whenever you are writing the prescription safety first. So we have got various organization which control this, US FDA we know, European Union EMEA, and in India Central Drug Standard Control Organization of Ministry of Health. Now, what is teratogenesis? One should know what is the principle of teratology. A teratogen is a chemical substance that can induce a malformation during development. So it acts with the specificity. This produces a specific abnormality or constellation of abnormalities. For example, thalidomide produced phocomelia. Valproic acid produces neural tube defects. Teratogens, they demonstrate dose-effect relationship. Teratogens must reach the developing conceptus in sufficient amounts to cause their effects. The effect that teratogenic agent has on a developing fetus depends upon the stage during development when the fetus is exposed. And there are upcoming new terms like pharmacogenomics, the use of genetic information to guide the choice of drug and dose on an individual basis. And idiosyncrasy, we all know about the aspirin idiosyncrasy. So there are genetically mediated abnormal reactivity to a chemical in a small minority of individuals for which no definite genotype has been described. So these are the two terminologies one should remember. So type of harm to the fetus, there can be all or none. And in teratogenicity, there can be alteration of tissue development or organ formation in early trimester, or adverse effects on the fetus which can be functional, which results in the dysfunction of an organ or tissue after that organ or tissue has been formed. So we were talking about teratogenicity, and there are various factors like environmental factors, there are genetic factors, and in combination. So there is always tendency to blame drugs or lack of any physical test as a cause of teratogenicity or abortions or any problems. Patient may come to you, oh, I have taken inadvertently OC pills, which are category X, and they will tell that you about this, but we know that OC pill does not means in the long term. We have seen that they don't have any adverse effect on the this one, fetus. Gynecologists have to treat many common ailments in the pregnancy, and as a patient, they do not trust any other physician. We tend to prescribe ourselves. So many times we get the prescription from dental. A woman goes to dental extraction, and she will come with the prescription. They will not ask LMP, and they just write any antibiotics which are not feasible, which should not be given in first trimester or last trimester. So they usually come to us for right or wrong. So this is we know about the malformation due to maternal ingestion of thalidomide. Now we should know about how the development occurs, and how at what level the teratogen can act. My slides are not moving. Yes. So whenever there is a effect of the timing of teratogenic exposure, in this slide you can see the loss of conceptus can occur if the teratogen act within two weeks of LMP. Then major morphological abnormalities can occur up to 8 weeks, and in the later weeks of pregnancy, the functional abnormality can happen. If you see the embryo and fetal age, which affects the type of drug effect, up to 4 weeks post LMP, all or none effect, the teratogenesis is unlikely during this stage. During organogenesis, 4 to 10 weeks after LMP, teratogenesis is most likely at this stage. And after organogenesis, at the end of second and third trimester, teratogenesis is unlikely, but drug may alter growth and function of normally formed fetal tissue, organs and tissues. Now, if you see the short-term and long-term consequences of medications in pregnancy, so if you, thalidomide it was detected at or shortly after birth. Long-term latency, you know the example of diethylstilbestrol, which has increased risk of vaginal adenocarcinoma after puberty or abnormalities in the testicular function and semen production. If you see the about the predisposition of the metabolic diseases, we know about the Barker's hypothesis, where also we see the consequences of these medications, and altered in utero and environment. Impaired intellectual and social developments is also one of the example. If you see the exposure of phenobarbital, which alters the programming of the brain. Now this is very important slide you should click for. This is various human teratogens you can see here, and the related outcome and what are the effects. For example, I cannot read all those the drugs you can take it. For some of the important thing is alcohol can lead to fetal alcohol syndrome. Carbamazepine is known to have the neural tube defect and fetal anticonvulsive syndrome IUGR. Then misoprostol, inadvertent taking of misoprostol can lead to Mobius syndrome or association and limb defects. And tetracycline can lead to weakened fetal bones, tooth enamel dysplasia, and permanent tooth discoloration. Some of them I have just gone through, but each and everything I cannot. So these you can just save, and you can go through. In further discussion, definitely I'll be talking about this. Whenever the patient comes to you about inadvertent drug exposure during pregnancy, so counseling of this exposed gravida is very, very important. First and foremost is one should always take a full medical history and examine the patient, identify what are the drugs she has taken, gestational age at what she has used, and you must know the teratogenic effects of these drugs and other risk factor. And if the drug is potentially teratogenic, then you have to again confirm the gestational age by ultrasound. Drug If it is taken outside the organogenesis, then if you think that there is a rule out the possibility of any adverse fetal effect. If a drug is taken during critical period of embryogenesis, you have to refer to the targeted ultrasound scan, and you have to also advise about the other prenatal test as indicated. So these history taking, ultrasound, other tests, and counseling forms a part of the whenever the woman comes to you with exposed teratogenic drugs. Now these are the common prescription which are needed for pregnancy ailments which are not related to pregnancy. You always come across any headache, vomiting, backache, then any allergy. So you should know about what all prescriptions can be given. First and foremost is cough and cold. So these are the drugs which are commonly prescribed, like xylometazoline and oxymetazoline, decongestant and inhalers. There is always you see these are the common prescriptions and there is no teratogenicity found. So all common preparations are safe. Antihistaminics, these are the drugs, chlorpheniramine, then hydroxyzine, and all these promethazine. These are all category B drugs, so they can definitely be given safely. And second generation also, like cetirizine, which is commonly prescribed, this category B, so you can safely prescribe. No, whenever the patient comes with the pruritus in pregnancy, you have to investigate them. What is the cause of pruritus? Symptomatic, definitely you can give, but the pruritus in pregnancy you can just think of other causes of pruritus, like it can be a hepatitis or any other things. So cholestasis also. So you have to investigate. I'll not go into the investigations and other thing. I'm just talking on the treatment part. So the rhinitis and pruritus, first choice is first generation agent is only chlorpheniramine or dexchlorpheniramine or hydroxyzine. If there is a lack of response or need to use a second generation, then loratadine and cetirizine are preferred because there are no teratogenic effects. Now, drugs in the dermatological lesions, many times the patients come and local topical corticosteroids can be used with a low risk to the fetus. So they are category C. And topical povidone iodine and podophyllene place a fetus at risk and should not be recommended during use during pregnancy. We also know that retinoids and antineoplastic, isoretinoin used to treat acne vulgaris, and antineoplastics like methotrexates. These are category X drugs. Okay, so antipruritic agents also like doxepin and hydroxyzine should not be used in the first trimester. So this is usually common prescription given, and you should. That's why I repeatedly tell that you should ask LMP. So it is known to cause severe birth defect, neuropsychological impairment, spontaneous abortion, preterm birth, fetal death, and even internal abnormalities. So it is very dangerous prescription whenever you are giving vitamin A analog. Now, drug therapy for fever in pregnancy. I think 2 days back, Talukdar sir has already discussed in detail, but I will not go in the drug therapy of fever because already it has been discussed. So symptomatic therapy is hydration and paracetamol, and if it is a presumed flu, antiviral drugs can be given, or specific bacterial etiologies or antibiotics are given. So if it is a H1N1 infection or influenza, you should promptly treat because hyperthermia can lead to various other complications. So prompt therapy with oseltamivir or zanamivir is preferred, and it is category C, but here the benefit outweighs the risk. Now, these drugs in COVID-19 in pregnancy, just I have listed these drugs. See, so many antivirals are there, then hydroxychloroquine, which is also immunomodulator. Chloroquine is used for malaria, heparin, betamethasone. These are the drugs which are used commonly for the COVID-19 19 in pregnancy. So FDA category, we know this antivirals is not still assigned, but the dosages you should know, and here also benefit outweighs the risk. So it is preferred. Azithromycin is commonly given, and of course, the only statins which are given, it doesn't have any data in pregnancy category X. So these are the commonly used drugs. Now, most common prescriptions are antibiotics in pregnancy. The reasons for over prescription of antibiotics in pregnancy is all fever. After it, if it doesn't subside, they take it as a sign of bacterial infection. And there is a lack of microbiology facilities at periphery. Patient also expect that some antibiotic should be prescribed, and there is a lack of knowledge about the appropriate or inappropriate use of antibiotics, and this all has lead to antibiotic resistance. So there is a what is antibiotic stewardship. This is a program which encourages judicious versus injudicious use of antibiotics. So every institution has got their antibiotic policy. These antibiotics are relatively so effective, non-toxic and inexpensive, so easy to use, they are prone to get abused. So whenever there is diagnosis is uncertain, the antibiotics are prescribed. So what is this stewardship is to tune the antibiotics treatment in regard to efficacy, toxicity, resistance, induction, cost, and discontinuation. So this is very important about the antibiotic stewardship you should know. So if you see in general where we use antimicrobials in pregnancy. So one is urinary tract infection, symptomatic bacteriuria, then any infections like endometritis during cesarean, post-cesarean, wound infections, then postnatally mastitis, and any vaginal infections, any pneumonias, all those in common causes of infections during pregnancy. So here also you should always remember about the pharmacology and safety of antibiotics. Now we studied about the physiological changes. So sometimes if that when we call that there is an expanded intravascular and extravascular volume about more than 50%. So there is an increased volume of distribution which needs a larger loading dose. So this physiology you should remember. And secondly, there is an increased progesterone activated hepatic metabolism. So increased rate of biotransformation. So again, there should be increased dose or decreasing dosing interval. So this we have already discussed about in the pharmacokinetics. Now, various antibiotics which are commonly used are one is in urinary tract infection commonly used is nitrofurantoin. It is category B, but one should remember that we should not use at the in the last trimester because we don't know about the G6PD deficiency in the fetus, and it is likely that fetus can have hemolytic anemia. So in the first trimester and the last trimester, usually it should be avoided. There are other list of antibiotics. I cannot go through all these, but you just see that tetracycline is category D. And if inadvertently given, then fetus hypospadias, then so many limb hypoplasias, you know that tetracycline stains the teeth, all those complications. So that's why it is not at all recommended in pregnancy. So these are the various other antibiotics. Most importantly, I want to highlight here is fluoroquinolones. Okay, it is category C. So quinolones, they have found that in animals there is arthropathy. So quinolones should not be given in pregnant women so that it affects the neonates and it. But there are no human reports till now. But they say that there are some reports in animal studies that there is a arthropathy. Likewise, aminoglycosides like gentamicin and all, streptomycin, amikacin, tobramycin, these are the drugs which cause fetus ototoxicity. So do not use in pregnancy and unless the benefit outweighs the risk to the mother. So these are the contraindicated drugs. So you write it. that quinolones, ofloxacin, ciprofloxacin, dimethoprim first trimester, aminoglycosides, and tetracycline. These are contraindicated drugs. And what are the safe drugs are ampicillins, cephalosporins, then penicillin group like carbapenems. These are safe. Azithromycin is safe because less than 3% crosses the placenta. Erythromycin, there are no much studies. Now, these are the recommended antibiotics in urinary tract infection. Cephalosporin, amoxicillin, nitrofurantoin, as I told, avoid near term. Acute pyelonephritis, cephalosporin and com amoxiclav. Chest infections, amoxicillin, erythromycin. Skin infection, erythromycin. And if there are any vaginal infection, you can give the topical clindamycin. So these are the drugs you should know, and these are the details of drugs. One should know what are the various penicillins. When you can use extended spectrum penicillins, and only thing in penicillin, they cross the placenta readily, so there is no evidence that they are teratogenic. So these are the various things you should remember about penicillin. Macrolides, these are the major antibiotic groups, and these are commonly used. So they are very, very effective against the Neisseria, gonorrhea, and chlamydia. Then cephalosporins are the other group which are commonly used in post-cesarean or postnatal infections or any chest infection. These are the first line of drugs which we are using. So there are first generation, second generation, and third generation cephalosporin you should know about. About tetracycline I have discussed, so I will not tell again. And other drugs which one should also know about: the clindamycin, metronidazole, and chloramphenicol. Chloramphenicol is a drug which can lead to aplastic anemia and hypersensitivity reactions and blood dyscrasia. And many times we have seen the neurotoxicity as well. So these drugs are not used. Aminoglycosides, I have already told that we don't prefer these unless the benefit outweighs the risk. So these are the categories of drugs. Categories of drugs you should know according to the risk. So this is the chart of all the antibiotics which are categorized here, especially antivirals also. These are categorized. So about the anti-tuberculosis drugs. So these are the drugs which are used commonly: rifampicin, ethambutol, isoniazid, and pyrazinamide. These are the commonly used. And the drugs which are contraindicated in tuberculosis are streptomycin, kanamycin, amikacin, capreomycin, and fluoroquinolones. These are not to be used. And we know that there is very emerging drug resistance. And in these women, you should cautiously prescribe the drugs, and after doing all thorough investigations. So this is a drug regime which is commonly used, and the major side effects is on liver. So if you are prescribing isoniazid, you just watch about the hepatitis, okay? And even pyrazinamide is known to cause hepatotoxicity. Okay, so these are the things you should remember about the anti-tuberculosis drugs in HIV in pregnancy. We know that whenever the woman is infected with HIV during antenatal period, they should immediately initiate it with the 3-drug regime. And these 3-drug regime, regardless of clinical stages of CD4 count, according to NACO and WHO guidelines. So even though the incidence has come down, it is said that it is only 0.22, but even then, whenever the patient comes as HIV positive, immediately, and this treatment should be lifelong. You have to counsel the woman properly, and even the neonate should be followed till 18 months. So you should say that these 3-drug regime, that is tenofovir, that is 300 milligram, then lamivudine 3 TC, that is 300, and efavirenz. These are the 600 milligrams. So these are the 3 drugs which are used in HIV. Antiparasitic, what are the uses? Unless very relatively common infections, but they are withheld unless the pregnancy, since many such infections are mild and asymptomatic. But the most important is anti-helminthitics, because these are the main things which lead to malabsorption and anemia. So every woman after second trimester at 27 to 28 weeks, we give 1 dose of albendazole or mebendazole. So it is very effective for including all the worms. So these you should remember. So other lice infestation and all that can be treated locally, but you just avoid first trimester. The if you see the label of this tablet cover, it is there, it is written that it is caution in pregnancy, but there is no effect on the occurrence of any congenital abnormalities in the babies whenever this woman is taking albendazole. Now various antifungals, the various fungal infection, we treat them, and these drugs are FDA category C. So side effects of nausea, vomiting, these are usually say that local means whenever there is a candidal vaginitis, you have to treat them candid with the infection like fluconazole and all. And the local treatment is quite effective. Like we give the local vaginal tablet, no, that is quite effective. So and local topical any fungal infection can be treated with fluconazole ointment. Now, various drugs which are used in gastrointestinal disorders. These are the various common disorders, and the most common is the vomiting in pregnancy or hyper and excessive vomiting like hyperemesis. So these are the drugs like doxylamine, diphenhydramine, then meclizine, promethazine. These are the drugs which are used for the vomiting in pregnancy. And there are class A and class B drugs. And we start with the pyridoxine 25 milligram 8 hourly and thiamine 250 milligram IV. And along with that, doxylamine to 12.5 milligram 12 hourly. So these are the combinations we can use. And first, and the second line is dopamine receptor antagonist like prochlorpromazine, metoclopramide. Many times we see that we commonly give these drugs, and chlorpromazine and droperidol. So there are side effects of these drugs, and this is an upcoming drug that is serotonin antagonist. Most of us we use ondansetron, 4 to 5 milligrams, 6 to 8 hours per orally, or 4 to 5 milligram IV 12th hourly. So the side effects being headache and constipation. Recently, they say that if you give in first trimester, there are few reported cases of cleft palate with ondansetron. But still, we have to find out. Only few case reports we have, but we are using it safely, even though it is not FDA approved for vomiting in pregnancy. So this is a common protocol of nausea, vomiting of pregnancy. First line of drugs are pyridoxine, doxylamine. Then if there is no response, then you add pyridoxine, diphenhydramine, and or metoclopramide, or prochlorpromazine, or promethazine. If again no response with this treatment, you add ondansetron. Many of them directly put the patients on ondansetron. And in the refractory cases, even steroids are used like methylprednisolone along with the IV fluids with hydration, and you add thiamine if the vomiting persists more than 3 weeks. Now, drugs in acid peptic disorders, all any acid peptic disorders you take, and any sucralfate or any antacids. Antacids are very safe in pregnancy. You can prescribe them. And histamine 2 receptor antagonists like cimetidine, famotidine, ranitidine can be given. And these are class 3 drugs. Okay. So in animal studies, they have written that there is embryo toxicity, but where only few are case reports that they are embryo toxic and all, but acceptable in some of the cases. Only ondansetron, I have 2-3 reports I went through. They have cleft lip and cleft palate. The proton pump inhibitors are very safe because they are class B like pantoprazole, lanaprazole, esomeprazole, and rabeprazole. These are the drugs. They are all class B drugs and they are safe. Antidirals are commonly prescribed like loperamide, absorbent, and bulk agents. These are category B and they are not teratogenic. So they can be safely given. Constipations like constipation also, we give bisacodyl, lactulose, milk of magnesia, and various suppositories. This can be safely given. But only thing is lactulose. Lactulose is a osmotic laxative, and it should not be given in diabetic because it can cause some problems. Like it is a osmotic laxative, and plus it can have a sugar. Now sugar free also they have it has come. Now milk of magnesia. This is a magnesium hydroxide liquid. This is also a osmotic laxative. Okay, and in pregnancy you can safely use bisacodyl suppository also. Now, about the epilepsy, which is very important, epilepsy in pregnancy, what are the facts? Although all anti-epileptics are teratogenic to some extent, stoppage or reduction of these anti-epileptics can lead to status epilepticus and subsequent hypoxia to the fetus. Epileptic woman, who is planning to get pregnant, should be always on higher level of folic acid. If you are giving 400 microgram for every patient, this patient may need 5 milligram. The fetal malformation are lowest with the monotherapy of anti-epileptics. So patients should be maintained on that while attempting pregnancy. Hydantoin and carbamazepine, these are the two drugs can cause bleeding disorders as well. So in these patients, we have to give vitamin K, which should be given concomitantly. So the conventional anti-epileptic like carbamazepine, phenytoin, phenobarbital, or valproate, these are all D group. And there are newer anti-epileptics which are emerging like levetiracetam and clobazam, oxcarbamazepine, and lamotrigine. These are the class C drugs, and they are very, very effective. The teratogenicity is lesser with the use of newer anti-epileptics. Among various conventional anti-epileptic drugs, if you see, this valproic acid has got a maximum teratogenic potential, and so use during pregnancy is associated with lower verbal IQ in children. So this is what one should know about the anti-epileptics. Here, the benefit outweighs the risk, so anti-epileptics should be continued, but you have to do the proper counseling of a woman in these patients. So what does the Indian Epilepsy Society consensus document you should know? So valproic acid preferably should be avoided as a first line of drug for the treatment of epilepsy in girls and women of reproductive age. It may be avoided in obese women with history of menstrual irregularities or PCOD, and the dosage should be maintained below 600 milligram for an adult woman. It can be continued in low dose in women with the reproductive age group who are already in long-term remission of epilepsy while on valproic acid. Now, fetal carbamazepine syndrome is what we should know is a facial dysmorphism and fingernail hypoplasia, and there is unclear risk of neural tube defect or developmental delay whenever the patient is on carbamazepine. Now, neonatal effects are transient hepatic toxicity, cholestatic hepatitis, or direct hyperbilirubinemia. And neurobehavioral, there is no association between carbamazepine and significant cognitive dysfunction. So another important thing of whenever the patient comes with the complaint of depression during pregnancy, we know about the postpartum depression, but now with corona and all, we have depression and psychotic patient during pregnancy as well. Around 15% is the incidence. So we cannot neglect that many patients in urban area, they come with the uh, this common complaint of depression. For everything they have depression. So risk of depression is greatest in the last trimester, and pregnancy as well increases the risk of anxiety. 30% of the women experience such symptoms, and obsessive compulsive disorders is worsened in pregnancy in first one third patients. Okay, so use of selective serotonin reuptake inhibitors like SSRIs, antidepressants does carry some risk, but the risks are very small. So definitely sometimes we have to prescribe these drugs and monitor the fetus. Now, really we have to worry about it because there is a paucity of data to help the guide the decision about the drug dosing during pregnancy. How much drugs? So we have to take a consultation of psychiatrist. So antidepressant are the most common psychotropic drugs. So rate of major birth defects in general population is 3%, and less than 1% are thought to be secondary to this drug exposure. So we have to this again think of what is a primary problem in a pregnant woman. Now, drugs in the respiratory disorders in pregnancy, these are the common drugs in asthma. So these are anti-inflammatory, beta-adrenergic agonist, then methylxanthines, antihistaminics, decongestant, cough medication, antibiotics, and anticholinergics. Out of which adrenergic drugs, these are safely can be used and in asthma, and they are safe. And even the steroids, we know that they are locally acting and they are given as a puff. These are also relatively safe in pregnancy. And we know that whenever we are giving steroids, we have to taper the steroids, and we have to weigh that how much the patient is breathless, how much she is having her oxygen saturation is maintaining. So depending on it is always tailor made treatment for this asthmatics. One thing you should always remember whenever you are treating the patient of asthma, that whenever you are giving this asthmatic patient, you should not give beta blockers. It can lead to bronchospasm. Cyclopropane as anesthetic agent can also lead to bronchoconstriction. Opioids, sedatives, tranquilizers, they also depress alveolar ventilation. And of course, we always talk whenever the patient has a PPH, we always ask her any history of asthma. So prostaglandin F2 alpha also lead to bronchoconstriction. So these drugs should be avoided whenever the patient is asthmatic. Now, various diseases particular to the pregnancy, like the medical disorders, of course it will not be possible in such a 1-2 hours to cover each and every medical disorders in pregnancy. Maybe in short I will discuss few of them. And preterm labor, which is very common entity, we always discuss whenever we are discussing about the management of preterm labor. So tocolytic therapy, there are conventional treatments and newer, and there are limitations of this. Overall, if you see this myometal cell, the tocolytic drugs, they act on various part of myometal cells. Beta adrenergic receptor agonists, nitric oxide donors, calcium channel blockers, oxytocin receptor antagonist, and COX inhibitors. These are the drugs, and there are many more drugs which are used for the tocolysis. The main thing you should always remember whenever you are giving tocolytics is general contraindication of these tocolytics. One and most important is non-lethal congenital or chromosomal abnormalities. Second is intrauterine infections. Third is whenever the patient is having severe preeclampsia, placental abruption, advanced cervical dilatation, fetal demise, and chorioamnionitis. You should always use cautiously in some of these conditions. The most of the currently used tocolytics, they act on non-myometal tissues also. This is what one should know, that beta adrenergic receptor agonist, it also acts on myocardium, smooth muscle, juxtaglomerular cells, skeletal muscles, and liver. So these are the other non-myometal tissue response of these agents. Calcium channel blocker act on vascular smooth muscle, and also they act on cardiac conduction. Magnesium sulfate, uh, it not only acts on the smooth muscle but also brain NMDA receptors or neuromuscular junction blockage. Nitric oxide donors, they act on vascular smooth muscles. So the primary target is, our target is myometal cell, but there is a wide distribution of this responsive tissue is a major determinant of numerous undesired side effects of these agents. So just think of these drugs, you will know that what will be the side effects. So your choice of tocolytics, the specifically developed uterospecific. If this question is asked in examination, so two things. One is oxytocin receptor antagonist is atosiban, is the only specifically developed for the uterospecific. Secondly, which is not specifically developed, which is not uterospecifics, are beta agonist, nitric oxide donors, non-steroidal anti-inflammatory agent, calcium channel blockers, magnesium sulfate. The licensed preparations are only two. One is oxytocin receptor antagonist, that is atosiban, and second one is beta agonist, that is ritordine, isoxaprine, terbutaline, salbutamol, and phenterol. So these are the only two, and other all are unlicensed preparations. They are not approved by regulatory authority, but we are using off label. So about atosebon, just few words. These represent an advance in the currently available tocolytics. It is specifically developed for the tocolysis, acts on the myoepithelial tissue, best maternal and fetal safety profile. It is only tocolytic drug without serious adverse drug reaction. It is safest choice in multiple pregnancy, expanded blood volume, anemia, where other tocolytics predispose to the pulmonary edema, especially beta mimetics. Now, this is how the dosage is, which is administered intravenously in three successive stages. One regime is zero point 0.9 ml IV injection, which can be given as a bolus. It should be given by infusion pump, and the bolus should be given 6.75, given over 1 minute. Then IV loading infusion can be 300 microgram per minute for 3 hours, and then you have to continue that 100 microgram per minute up to 45 hours. Now these are the various, in nutshell, all the tocolytics which are in use. One most commonly we are using is nifedipine. What is the mechanism of action is it blocks the entry of calcium inside the cell. So first dosage we give is 20 to 30 milligrams, start 20 to 30 milligram every 3 to 6 hours, and maximum you can give up to 160 milligram in 24 hours. The side effects are hypotension, nausea, and if you have to hold the this drug if the pulse rate is more than 120, and never it should be given concomitantly whenever you are giving magnesium sulfate. Okay, so magnesium sulfate is given as a neuroprotection as well as tocolysis, but mostly we give as a neuroprotection directly. We for the only for the tocolysis we never use. So whenever we are giving as a neuroprotection, it is same like we are using for eclampsia, that is 4 to 6 gram IV over 20 minutes, followed by infusion of 1 to 2 gram per hour for 24 hours. So it is relatively safe, and flushing, these are the side effects one should know. So after 24 hours, we stop magnesium sulfate so that the steroids also act and neuroprotection occurs. Now about the beta mimetics, which are again coming up, retardine 50 microgram per IV every 10 minutes till the contraction cease, and we can give as an infusion. Then we can give terbutaline, which was very popular earlier, subcutaneously 0.25 milligram every 3 to 4 hours. So these are the common drugs. So I am just going in detail. Otherwise, you know all these drugs. Okay. The side effects of beta mimetics is most common is hypotension and cardiac arrest and pulmonary edema. So these are the things you should remember, that whenever you talk on beta mimetics, you first side effects you should tell about is a pulmonary edema and cardiac arrest. So you have to monitor whenever you are giving beta mimetics, especially you are giving isoxaprine hydrochloride in a drip. So you are increasing the drip 8 drops, 16 drops till the contraction ceases. So you have to monitor her pulse rate and blood pressure very carefully. The atosebon, I have already told you the dosages. The side effects are tachycardia, nausea and vomiting, which is very less. You can also use nitric oxide patches also. So patches can be again 8 hourly you can change, and hypotension is another factor. The most uncommon drugs are indomethacin. Now indomethacin you can use in whenever the patient has some polyhydramnias. The indomethacin has uh, newborn adverse side effect, like it can lead to the constriction of ductus arteriosus in utero and patent ductus arteriosus in newborn. So it should be at the late treatment you cannot use. ಅದು Yes, yes. Hello, am I audible?
Madam, you're audible, madam. I can hear you.
Yes, no, no, in between, yeah. I was talking about the calcium channel blocker and non-steroidal anti-inflammatory drugs and beta-adrenergic receptor agonist and their side effects and contraindications. The magnesium sulfate, as I have told, as autocolysis, you as a first line of drug we never use. We use as a um, neuroprotection. It has got effect on the neonate. So we have seen the magnesium sulfate causing neonatal depression. The contraindication, which is commonly asked, where the magnesium sulfate cannot be used, actually they say that hypercalcemia and hypersensitivity, and the real contraindication is a myasthenia gravis. The history of myasthenia gravis is there. You cannot use that. So it is. Another thing you should remember that whenever you're using magnesium sulfate in the dose and duration of fetal neuroprotection alone, it is not does not appear to be associated with the increased risk of neonatal depression. So you can use it as a neuroprotection. About the steroids which we are using in pregnancy for various reasons. Most commonly, we are using for the lung maturity of the baby. So how it acts? So these corticosteroids, they accelerate the development of type 1 and type 2 pneumocytes and increase the surfactant. So these are the main reasons for which we are using corticosteroids. There are other mechanism of action also, but I'll not go into that. And ACOG and all, everybody, Foxy, everybody, even National Health Mission, they advocate the single course of this corticosteroid, which is recommended for the pregnant woman between 24 by 7, 07 weeks to 33 by 6 by 7 weeks of gestation who are at risk of preterm delivery within 7 weeks. I'll not go into the detail about the repeated course and all course and that, but dexamethasone is preferable to betamethasone because of various reasons. So the choice of drugs, and betamethasone is given as 12 milligram, two dosage, 24 hours apart, and dexamethasone 4 doses, 6 milligram, 12 hours apart. So why dexa is, these steroids are less extensively metabolized by the placental enzyme 11 beta hydroxide steroid dehydrogen type 2, and the efficacy of alternate dosing regime is unproven. So dexa is preferred over betamethasone, that much you remember. About the hypertensive disorders in pregnancy, there are various international, national guidelines and gestosis guidelines for the treatment of hypertension in pregnancy. It is reasonable to conclude that systolic blood pressure more than if 150 or diastolic more than 100, it warrants therapy. Okay, so now it has come down. I will not go on discussing that. But which drug to choose? The first line is methyl dopa or labetalol, second line nifedipine, and if it is added to the first line if there is no response. Drugs which are not to be used in pregnancy are ACE inhibitors, atenolols, and beta blockers. The acute hypertension which are commonly used drugs are hydralazine, labetalol, and nifedipine. So hydralazine is not commonly available, and we all are used to about labetalol. Hydralazine, but you should remember the dose 5 to 10 milligram every 20 to 30 minutes, and the onset of action is 10 to 20 minutes. Duration is 3 to 6 hours, and the adverse effects are tachycardia and headache and flushing. So labetalol, we give, everybody has got this, which commonly used is 10 to 40 milligram IV, 10 in 10 minutes. Onset of action 10 to 20 minutes, duration around 3 to 6 hours, and the side effects are vomiting and heart block. The nifedipine 10 to 20 milligram per orally, never give sublingually, every 20 to 30 minutes. The onset of action occurs 10 to 15 minutes, and the duration is around 4 to 5 hours. The headache and tachycardia are the side effects. So another drug which is used in ICU is nitroglycerin sodium nitrochloride. The onset of action is very quick, like 0.5 to 5 minutes, and the dosage schedule it should be given as 5 microgram per minute IV, 0.255 microgram per kg per minute IV. So it is short-term therapy when other drugs have failed. Okay, so this is what we always keep in our labor room or anywhere eclampsia room. That this is how we give the labetalol 20 milligram IV, 10 minutes. If BP does not get control, again repeat the dose, and again you can repeat after 10 minutes 40 milligram. So maximum dose of labetalol is around 300 milligram. This is our gestosis slides. And labetalol I have written little detail about it is a category C drug. And one should always remember that it is a beta 2 blocker, so that you can, in 10% of the cases you will have bradycardia and dizziness, and in bronchospasm, dyspnea, and elevated serum creatinine. So these things you should always remember, and it is contraindicated. This contraindication you should remember, that you should not give in asthmatic patient if the patient is having severe bradycardia and third degree heart block. Nifedipine is a calcium channel blocker, and you can 10 milligram dose can be increased to 1 till 120 milligram per day. There are slow release preparation also, we know that retard. Here again we cannot give the sublingual dosages. Sublingual we should not give. So this is in nutshell the chart. How much, what is mechanism of action, dose, side effect, and contraindication. So you have to remember these are the antihypertensive which are commonly used in the hypertension in pregnancy. Okay, so at the end, one should remember that nifedipine, hydralazine, labetalol, they have similar efficacy in the treatment of severe hypertension. They are effective oral treatment also. But when single drug is available, nifedipine or labetalol, which will be preferential to methyl dopa, because methyl dopa, when earlier it was available, now everywhere it is not available, but it is a very good drug and it is a B category drug. And whenever you take the methyl dopa, the action start happening after 24 to 48 hours. So that much time we don't have. So labetalol and nifedipine are better drugs, and they act early also. Now about the magnesium sulfate in detail. So magnesium sulfate already have described in tocolysis. So first and foremost indication of magnesium sulfate is used in a prevention and control of seizures in eclampsia, and as a prophylaxis. So there are two, three regimes, and we know all the regimes like Pritchard regime and Zuspans regime. Zuspans regime is IV regime, and it is very easy to give also. 4 to 6 gram IV over 15 to 20 minutes, and then you have to increase to 1 to 2 gram IV. And we know that what things to observe. One is patellar reflex and respiratory rate and urinary output. Because the excretion of this magnesium sulfate is solely by kidneys at the rate proportional to the serum concentration and glomerular filtration. We need not do magnesium levels, but these are the clinical parameters where we can monitor the magnesium levels. So patellar reflex, if it is gone, it is more than 10 milliequivalent, like that. We have clinical judgment of this magnesium toxicity. Okay, so neuroprotection have already discussed, so I'll not go into the tocolysis and neuroprotection for the magnesium sulfate. Now, various endocrine disorders in pregnancy. About the drugs, thyroid disorders in pregnancy, the levothyroxine, which we use commonly in hypothyroidism, it is the category A drug. So it is very, very safe drug. It is available as 25 to 300, and whenever micrograms, and the dose 30% increase from the non-pregnant value if the patient is already hypothyroid. If it is newly diagnosed in pregnancy, you have to give 1 to 2 microgram per kg per day, or approximately 100 to 150 microgram of levothyroxine daily. So after you give, you have to measure the TSH levels 4 to 6 weeks following the dose change, with TSH goal between 0.5 to 2.5 international unit per liter. Once stable, the TSH can be checked every 8 weeks. So you should remember these dosages. The adverse reactions with the levothyroxine on mother related to the over treatment. If you treat them over, hyperthyroidism is one possibility. There is a transient hair loss and decreased basal metabolic rate. On fetus, they have found that with the levothyroxine, there is smaller head circumference and low birth weight. Now, about the hyperthyroidism, there are two drugs like propylthiouracil, which inhibits the conversion of T4 to T3. It crosses the placenta less readily, but the dosage is around 300 to 450 milligram in three divided dosage of 100 to 150 each. And the improvement is usually within 3 to 4 weeks, and full response you can get till 8 weeks. And it is tapered as the pregnancy progresses. The side effects are iatrogenic fetal hypothyroidism and transient leukopenia, agranulocytosis, hepatotoxicity, and vasculitis. These are the common complication side effects of propylthiouracil. So propylthiouracil is a preferred drug than methimazole, but methimazole the dosage is very easy, and it is a category D drug. It crosses the placenta more readily. So we don't prefer this drug in the first trimester. Once the propylthiouracil is given, and then second, after second and third, methimazole for the can be given. One must know what is methimazole embryopathy, that is esophageal atresia, choanal atresia, cutis aplasia, and for this purpose we never give these drugs in first trimester. Side effects are leukopenia, granulocytosis, and hepatotoxicity and vasculitis. The dose is monitored with three to four weekly on free thyroxine levels. And improvement is usually seen in 3 to 4 weeks, and full response occurs in, again, this drug is also tapered as the pregnancy progresses. The fetal monitoring is very important when the patient is on anti-thyroid medication. 10% of the fetus which is exposed to the drugs, they develop fetal or neonatal hypothyroidism. So the monitoring is a clinical examination of the fetal growth. Ultrasound should be done for the bradycardia growth parameters, and sometimes you can find the fetal goiter also. There is symmetric tracheal mass and neck hyperextension and polyhydramnios. So cordocentesis in some of the cases they have advocated. About the diabetes and diabetes mellitus, this is a second common endocrine, first common actually. If you see the increased prevalence of gestational diabetes, these are the various drugs apart from medical nutrition therapy. The first line of therapy, they say that insulin is pregnancy category B. There are various types of insulin: short acting, rapid acting, intermediate acting, long acting. So these are the various drugs used, and the availability and various pens are available, and we know that they are tailor-made pens, and you have to monitor the blood sugar levels, and then you can give these patient insulin. Now these are the various drugs which are glyburide category C, glimepiride, glipizide. They all cross the placenta, and there are various studies on glyburide, and everywhere they have written that the insulin is the first line of the drug. But for oral hypoglycemic agent, glyburide, and the second one is metformin. These are the two drugs which are extensively studied, and we know about the MIG trial also. About the success rate, the glycemic control, the insulin is certainly more effective means to achieve the good glycemic control because of almost limitless ability to increase and titrate the dose to control the blood glucose level. With metformin, the glycemic control rate is only 54 to 79%. Earlier, we used to tell that whenever the patient is on metformin, when for the PCOS treatment, you just continue that metformin. But nowadays, now recent studies, they say that metformin, it can also lead to various other things, like it has got fetuses have macrosomia, and that sometimes it has to be supplemented with, as in this trial, it is the control is not very good with metformin. So whenever the metformin is given in few of the patient, we have to give the insulin as well, and it has got a higher failure rate. So there is a time lag, and these are, you have to of course see the patient and then decide. So there are neonatal hypoglycemias are very common with metformin. These are the gray zone with metformin. There is increased failure rate, And these are the various conditions where insulin is preferred. Like if there is a previous history of GDM, there is earlier diagnosis of GDM, then high baseline HbA1c. I'm happy Charmila is there. She has done published one study of HbA1c in gestational diabetes. So older age is contraindicated, history of any congenital anomaly. If there is a polyhydramnios, in this woman, we need a better control. In that, those patients, definitely we use the insulin. So it is up to you, up to the patient rather, and the conditions. So if the advantages, then these are the disadvantages. You should know the advantages. If you see the pharmacokinetics, so pharmacokinetics and mechanism of action. See, the main pathophysiology in GDM is insulin resistance. So they say that metformin is orally effective, so it is easy to give the patient, and periphery. The efficacy, glycemic control comparable to insulin, they say. And there is low risk of maternal hypoglycemia. Whereas if you give insulin, the maternal hypoglycemia things are uh, they have more hypoglycemic episodes. And social and other consideration, patients better acceptability, less cost, less need to self monitoring of the blood glucose. These are the other factors. Maternal outcome, there is no adverse maternal outcome, less risk of hypoglycemia, lower maternal weight gain, less risk of pregnancy induced hypertension, they say. But these are the some of the studies based on short term fetal outcome. No increased risk of teratogenicity in fetuses exposed in first trimester, no increased risk of perinatal complications, reduced neonatal hypoglycemia, reduced NICU admissions, lower birth weight, reduced risk of macrosomia. So long-term effects of exposure to effects, there is MIG travel, there is a trial, no evidence of growth or motor or social developmental abnormalities may result or more favorable distribution of adipose tissue in the offspring. So it has got again insufficient evidence. So we need more larger trials on these drugs. So it is negligibly secreted in the breast milk. So there are conflicting, so it is all the guidelines keep on changing. So you should know where the metformin should be given, how it is given, what is the dosage, what are the side effects, and what should be monitoring should be done. So you just compare with this. Satisfactory glycemic profile is obtained within 1 week it takes for the metformin. I want to say about the glycemic profile, but the blood sugar control is better. Immediate control is better with the insulin. So you should always think that whether you want a short term and long term blood glucose monitoring and adjustment. So dosing of metformin is always standardized, these many tablets. But insulin, it should be managed by the obstetric specialist only. They can only tell that this much blood sugar, you have to take this much. You know? So first trimester, what is zero point 0.7 international unit per kg? Like that, we have to see the blood sugar, you have to titrate, you can taper. All those things you have to monitor whenever you are putting the patient on insulin. And you have to always tell about the maternal hypoglycemia, which is very dangerous about to the fetus, whereas metformin is very easy to use. About the analgesia and anesthesia, I just want to go through quickly. Many times the patient, they come for some headache, some backache or something. So what antenatal analgesia you can use before 30 weeks of gestation during first trimester. So paracetamol is very safe and it is the first choice of analgesic. There is no risk of major birth defect. Of course, they say that if you are using paracetamol for longer duration, there is attention deficit disorders are very common. There are many papers published on that. Non-steroidal anti-inflammatory drugs, there is no clear evidence of increased teratogenic effect. Other analgesic may not work well. For example, severe migraine is there with the patient who is pregnant and she is having ankylosing spondylitis. In this patient, definitely you can use in a smaller proportion of the cases non-steroidal anti-inflammatory drugs. Opioids, there are some reports of increased neural tube defects. And gabapentin can be given in some of the patient of chronic pelvic pain. There are other analgesics we can use like fentanyl, morphine, meperidine. There are various wide availability of analgesic action for these drugs. And secondly, usually many of us prefer to give local analgesic ointments rather than giving orally. After 30 weeks of gestation, again paracetamol, non-steroidal anti-inflammatory drugs are avoided. After 30 weeks, it can lead to neonatal pulmonary hypertension and premature closure of ductus arteriosus. So you should avoid non-steroidal anti-inflammatory drugs after 30 weeks of gestation. So opioids around the time of delivery, labor analgesia, it can lead to neonatal respiratory depression. So you should not use opioids. And long-term use can also lead to neonatal withdrawal symptoms and maternal dependence. So you should be very, very careful whenever you are writing any opioids. Gabapentin, of course, has got very limited evidence. As I said about the paracetamol, we always say that everything is safe, but paracetamol, if the woman takes more than 1 week, can lead to reproductive problems in their male offsprings, according to various studies. So pregnant women need to use paracetamol. They should use to the lowest effective dose and for the shortest possible time. Now about the antispasmodic, which are commonly we write about the trotavirin tablets and hyoscine vitamirate tablet, dicyclomine injections we commonly give, but these are should not be used much, and you can as and when required, SOS what we call it as, but always there should be caution that you should rule out any obstruction or any inflammation. You should always exclude and give these drugs. About the obstetric analgesia, these anesthesiologists, they employ the following pharmacological agents. Like they give the parental opioids like meperidone, morphine, and fentanyl, and inhalation drugs. So we are really, they have their effects on the fetus as well. And these are the drugs. I just have given this chart about the placental transfer characteristic of these commonly used analgesic drugs. Here you can see the morphine is 2 plus, whereas fentanyl crosses easily placental transfer, and it has got a effect like fentanyl and petidine. It has got an effect on the neonate, like prolonged neonatal depression due to increased half life of these metabolites. So you have to observe these babies whenever these patients are getting anesthesia or analgesia. So these definitely has, they cross the placental this placental barrier and placental transfer. Autoimmune diseases during pregnancy, these are the few of the diseases like APLA, we know the antiphospholipid antibody syndrome, and these are the drugs we commonly use like aspirin, aspirin plus heparin, and prednisolone. These are the commonly drugs and they can be used safely. About the rheumatoid arthritis, paracetamol, as I have already told about the analgesic, they can be used and when that they should be avoided. So I'll not go into the details. And SLE as well. So SLE also they are using aspirin, prednisolone, hydrocortisone, and some of the immunosuppressant. You should be very, very careful whenever using. The drugs for cholestasis you use are urusol deoxycholic acid 300 milligram or cholestyramine. 50 to 60% of the patient get relief, but it also causes the vitamin K deficiency and fetal coagulopathy. This we should remember. And naltrexone, this is a opioid receptor antagonist which has been found to give relief from pruritus. So pruritus is, that's what I was telling, that whenever the patient comes as a pruritus, you should always think behind your mind that what is the cause. And in severe cases of these patients, we can also treat these cholestasis with dexamethasone tablets. So these are the common medications which are used for cholestasis in pregnancy. Now I'll not go into the uterotonics. All of us know and details of the oxytocin and the indications of oxytocin. The maximum daily oxytocin is around 60 units in whenever you are using postpartum hemorrhage. 40 to 60 units, because the oxytocin receptors whatever are there, no, they are maximally there stabilized with this dosage. So whenever you are asked about the indications for oxytocin, one is oxytocin can be used for induction of labor, ripening of the cervix, augmentation of labor. In cases of active manage it is not inactive management, it is inactive management of third stage of labor, and following the as a alternative as ergometry. So it is a first line of treatment in active management of third stage of labor and in PPH, but it is category X drug. So it is contraindicated in following conditions like uh, for augmentation or induction in contracted pelvis, any hypersensitivity of drug, and pulmonary edema. So these are the indications you should know, and in therapeutic indications, you know about the oxytocin. So ergot alkaloids like methargine, you should know about the indications, its pharmacokinetics, and the chemistry and the side effects. So ergometrin should never be used in hypertension and heart disease. And inadvertently used, sometimes it has led to the gangrene also of the any toes and all. It is contraindicated in vascular disease, cardiac disease, hypertension, and whenever you are giving methargine or any oxytocin, you always palpate after the delivery of the first baby, you have to palpate. Na? Is there any second baby? So in multiple pregnancies. Okay. So these are the other drugs like misoprostol is also category extras. We know that inadvertent taking of misoprostol in first trimester can lead to limb defect or Mobius syndrome. So it is always you should know about the side effects whenever you are prescribing any drugs. So indications of misoprostol, you should know about the termination of pregnancy, induction of labor, ripening of the cervix, and medical management of PPH. So in a nutshell, I have given everything, what is a dose and maximum dose of ergometrin which is asked is up to 5 dosage you can give up to 1 milligram, and you should repeat at the interval of 30 minutes. Okay, so I have given one chart at the end, and these are the prostaglandins like PGE2 and PGF2 alpha, and PGE1 and PGE2. That those are PGE1 is a misoprostol and PGE2 is a dinoprostone. So dinoprostone we are using for the this one cervical softening, like we use for it has got action on the cervix, so it softens the cervix, and it has got a longer duration also action. So these things you should remember, and contraindications of these prostaglandin is always you remember that it can lead to, in glaucoma you should not use. Okay, so and in it lead to tetanic contraction, so fetal distress also is another contraindication. Now, this is another drug which is WHO has listed in its essential medicine, and used in we are using it in PPH. Okay, so we are having other uses also, like we are using in heavy menstrual bleeding also, and it is a class of antifibrinolytic agent. It is category B drug, and it is available as an injection. So it can be given IM and injectable, and you always remember that it should be given when the coagulation system is intact. Never give when it is contraindicated in subarachnoid hemorrhage, or in all there no contraindication is hypersensitivity to the drug. So it is used for the active management of third stage of labor as an alternative. So how it is given? Orally you can give 500 milligram 3 times a day, or just before starting of the cesarean you can give 20 milligram per kg over 5 to 10 minutes. Maximum you can give around 3000 milligram in divided dosage. So this is very effective treatment, and that is tranexamic acid, which definitely reduces the blood loss. Okay, this is another very busy slide of recombinant factor 7E. So this is indicated in severe obstetric hemorrhage as an adjunctive treatment to the surgical hemostasis, and salvage to or rescue therapy in the refractory PPH, and mainly in some of the cases of hemophilia. So it is very costly, but it is very effective whenever the case comes. So if all treatment fails, you can definitely use this. And onset of action of this recombinant factor 7A is 20 minutes. So initial dose whenever you are giving or the treatment of severe PPH is 40 to 60 microgram per kg intravenously. And if it bleeding continues beyond 15 to 30 minutes following first dose, additional dose to be considered. Repeat every 3 to 4 times intervals till the clinical sign of bleeding persist or based on visual evidence. And if the response remains inadequate following the dose of more than 200, the preconditions admission for the administration should be rechecked and corrected. So you should always, whenever you are prescribing such an expensive drug, you should know that what are its limitations also. So maximum dose per day you can give up to 300 microgram, and the duration of action of this recombinant factor 7 is around 3 hours. Okay, so the side effects of this drug, you should remember that it is pain at infusion site, fever, headache, vomiting, changes in the BP and skin related hypersensitivity, and thrombosis. So this is another drug which is used in the management of PPH. Now this is a total chart. What are the choice of uterotonics which are used in PPH? So the first line, second line, third line, or in combination also many times we use. So misoprostol around 600 microgram, and the most side effects you always tell about misoprostol is pyrexia, right? The advantage of misoprostol is non-skilled attendant also can give this misoprostol. So what I wish to remember from this chart is we are not using carboprost as a third stage management, active management of third stage, but there are many studies available. The minimum dose which can you can use about carboprost is 125 microgram intramuscularly. It acts very early, less than 5 minutes, and it is also long acting. Again, it is contraindicated in asthma, but expensive. It can lead to bronchospasm, and it requires cold storage. So oxytocin, ergometrin, and carboprost you have to keep in the cold storage, whereas misoprostol can be kept outside. So the potency of the drug depends where it has been kept. So many times it happens that we go on giving drugs, but the effect is not there. It is because it is the potency is decreasing. Oxytocin, we have already discussed about this, and this is another chart where you can know the maintenance dose, maximum dose, and frequency and precautions you should take. So ergometrin, you remember that only 5 doses can be given. 1 milligram is the maximum dose. Oxytocin, I told about 60, around 40 to 60 units maximum you should give. About PGF2 alpha, carboprost, 8 doses maximum, that is 2 milligram. And frequency at what we can give this carboprost is every 15 to 90 minutes. You should avoid in asthma and heart disease, and never ever give prostaglandins intravenously. About the anticoagulants, these anticoagulants are various at their category C drugs. Where we are using these anticoagulants are in the treatment of DVT and pulmonary embolism, thrombosis, APLA syndrome, recurrent pregnancy loss. Whenever there is a prostatic cardiac valves as a thromboprophylaxis of high risk cases, thrombophilias, associated pregnancy complications like fetal growth restriction, RPL, and various cases. So it is available as an injectable. The onset of action depends on how you give. Okay, immediate action if you give subcutaneously, and the duration of action also depends on that. So uh, these are the various solutions are available, like 1000 units per ml, 2005 units uh, per ml, 5000 units per ml, as and you have to mix. They are pre-mixed IV solutions are also available. So you should know about the side effects. Now heat is heparin induced thrombocytopenia. What you should remember whenever this is one of the side effect of unfractionated heparin. So maximum dosage what we can give, you can give of unfractionated heparin is 45,000 units per day. And the routes of administration are as intravenous and subcutaneous. Contraindications are bleeding disorders or bleeding tendency, hypersensitivity to the drugs, and severe hypertension. So the dosage all differ from the disease the patient has. If the patient is, you are giving for the prophylaxis of thromboembolic disease, unfractionated heparin can be given 5,000 units subcutaneously every 12 hours, or you can give up to 7,500 12 hourly in first trimester, second trimester, third trimester, unless the APTT you have to monitor. And if APTT is more, you can reduce this. In thromboembolic disease, to I have to maintain this APTT up to 1.5 to 2. The treatment of APLA, if you consider the APLA, you have to give this unfractionated heparin 5,000 units subcutaneous every 12 hourly, or adjusted to maintain APTT value either 1.2 to 1.5 times the value at baseline or at upper limits of normal range. So it is also used in recurrent pregnancy loss as unfractionated heparin 5,000 units subcutaneous 12 hourly. We all use enoxaparin and dalteparin. There are more, but you should know the dosages of these anticoagulants. Now, onset of action, enoxaparin is 3 to 5 hours, dalteparin is 2 to 4 hours, and the duration of enoxaparin is 12 hours. And dalteparin is more long acting, that is 12 to 24 hours. So enoxaparin maximum dosage you can give is 150 milligram microgram per kg. Dalteparin is 18,000 unit per day. So these are given subcutaneously. The indications they remain same. The saline side effects are bleeding, elevation of serum trans aminotransferases, and thrombocytopenia, fat necrosis or hematomas, and the side effects are other side effects are fever, chills, urticaria, and rhinitis. So these enoxaparin is category B drug. So usually we prefer enoxaparin than the unfractionated heparin. So there multi-dose vials are available, even pre-filled syringes are available, and various dosages are, we know the dosages of unfractionated as well as these low molecular weight heparins. Okay, so another thing I just wanted to highlight is about the social drug exposure. In urban population, we come across various people who are having alcohol abuse during pregnancy. So one should always counsel these women about the drinking, and no level is safe. There are incidences of with alcohol, spontaneous abortion, stillbirth due to fetoplacental dysfunction, small for gestational age, and this alcohol intake can also lead to uh, ADHD, attention deficit syndromes, and fetal alcohol spectrum disorder as well. So these are the side effects of the social drug exposure on the fetus. Tobacco use is another things in rural population. So whenever the you see in the rural population increased tobacco use, you have to counsel about not to eat tobacco, because it can lead to impaired oxygen delivery, vasospasm, carbon monoxide and other chemical release, and chromosomal instability and lung development. Tobacco chewing can also lead to preterm delivery, low birth weight babies, small for gestational age babies, PPROM, placenta previa, abruption, fetal death even, asthma, and otitis media, idiopathic mental retardation. So it is very important that whenever we take a history, you have to take the history of these addictions. We always take, whenever take the history, these addictions are very important here. It has got its own side effects. Okay, smoking and use of nicotine substitutes in first 12 weeks, slight increase of congenital malformation, and we need to give pharmacotherapy for those who are unlikely to quit, but not during pregnancy because it has got its own side effects. Because sometimes counseling cannot work, so there are some pharmacotherapies, which medications which alter the behavior and they leave addictions. The cocaine use is another thing, can lead to preeclampsia, APH, of course, non-assuring fetal status, meconium, and neonatal abstinence syndrome. So there is, I don't know how the prematurity reduced risks, I have to find out, but this is from some literature. So you have to give in these patients supportive therapy, and methadone treatment, which is used in pregnancy, not it is not associated with birth defect. Okay, so buprenorphine of morphine is a good alternative for this cocaine. The hematonics I will not touch, but these hematonics, we should know what are the various tablets available. There are newer preparations which are available. What is the right dose? What we should give? There are sucrosomial iron, and most 80% of the women are anemic. So we usually give this iron, and the supplementation, whenever any tablet of iron you are giving, you have to supplement along with the folic acid, one thing. And you should tell them that not to take iron and calcium together, so that absorption, and when to take. There are many newer preparation, as I was telling about the micro encapsulated have come. There are iron sprinkles have come. So you should choose a ideal iron tablet which has clinically effective, which has got a minimal side effects, which are safe and cost effective. So you have to see the patient. You cannot tell them the tablets which are very costly that they cannot afford. So one is cost factor, second is their compatibility and compliance. All three matters whenever you are prescribing the oral iron, and you always see for the elemental iron what it has. So the dosage is usually the 60 milligram elemental iron therapeutic dose 3 times a day, and otherwise you have to maintain, and you have to give this tablet postpartum for minimum 6 months. So that you should remember. These are the iron sucrose. There are injectable irons which are available. The indication for parenteral iron is always asked, and whenever the woman is intolerant to the oral iron, non-compliant to the oral iron, there is a poor absorption of oral iron, there is no response to the oral iron even after 4 weeks with confirmed iron deficiency anemia. Of course, you have to rule out the other causes of anemia when there is no response to the oral iron, and repeat investigation to find out the cause. Then you can prescribe the injectable iron. So these intravenous irons, they have there are no reactions. There are newer iron available, iron sucrose, ferric carboxymaltose. It is contraindicated when there is a hypersensitivity, and usually we don't give any drugs in first trimester. Okay, so they are available from 2 to 2.5 to 5 ml to 10 ml, and you have to always calculate the hemoglobin deficit by 2.4 WD. So you can give the sucrose, iron sucrose 200 milligram per day according to her deficit. Okay, so it is a polynuclear ion, that is ferric hydroxide complex in sucrose. About ferric carboxymaltose treatment, whenever the oral preparation, this is very commonly prescribed drug nowadays, and it is very effective in postpartum anemia. It has got the same indications like iron sucrose, but we can give it as a single shot, and you can discharge the patient. Contraindicated in liver diseases, infections, and anemia not attributed to iron deficiency. So you can give these in 500 or 1000 single dose, and patient is very compliant for this, and only thing is a cost factor. So these are the Common complications which can occur. Usually there are no complications, but only minimal complication you should know. You can see that is it is very less complication, like little bit nausea, or you can have dizziness or tachycardia. These are there, and this is a Ganzoni's method of cumulative iron dose calculation. You should know this. Target hemoglobin minus actual hemoglobin in gram per liter into 0.24 plus iron stores in milligram, and then you calculate the total dose. Usually if the hemoglobin is less than 10 grams, you give 1500 gram give, and then body weight also you have to think over. So usually 1000 milligram you can definitely give. You can give by direct injection or bolus IV or infusion in sterile zero point 0.9 normal saline, and it should not be administered by subcutaneous or intramuscular. So it is a category B3 drug, you should remember. About the emergency drugs, I will not go into details, but you should know what are the emergency drugs and emergency tray, what drugs should be kept. So dopamine and dobutamine, these are the two drugs which are put in the emergency drug box. So the contraindications, you should remember that precautions in patients when they are having thrombocytopenia and hyperglycemia, and it has got a dopamine has got very short half life, that you should remember. In And it is metabolized in liver and excreted in urine. So always dopamine is given as an IV infusion, and immediate action you can reciprocate whenever you are giving. So the dosage is around zero point 0.5 microgram per kg per minute, and it is titrated upwards as an increment of 1 microgram per kg per minute. So maximum you can give up to 6 microgram per kg per minute. This is noradrenaline, is another drug. And this acts very fast, and the maximum dosage you can give up to 3.3 microgram per kg per minute. Acute hypotension, you start initially with 8 to 12 microgram per minute IV infusion, then titrate the effect. Maintenance of 2 to 4 microgram per minute IV infusion, and the dosage differs in cardiac arrest and sepsis and septic shock. So these are the common drugs which are used in shock. Alpha, and it is a class of FDA category C, but in emergency you have to use these drugs, alpha and beta adrenergic agonist. This is another class of drugs, progestogens, which is commonly used. These are the steroid hormones which are used, which are bound to the progesterone receptor. And where you are using, there are various varieties of progesterogens are available. So they are natural micronized progesterone, dihydrogesterone, then 17 alpha hydroxyprogesterone caprolate. These are the drugs which are used in pregnancy, and the various indications, I'll not go into the details of infertility treatment, luteal supporting ART, then threatened abortions where we use various types, and dihydrogesterone is preferred than micronized progesterone in threatened abortion, and the dosage is around 40 milligram stat followed by 20 to 30 milligram till 7 days till bleeding stops. Then you can supplement this. There are various controversial statements, and there are various studies of which progesterogens is better than one and other. It is again the dosage and the compliance. Recurrent abortion, the etiology is varied, but the micronized progesterone is preferred. And there are injectable progesterone which are very effective, like 17 hydroxyprogesterone, which are very effective injectable. There are various studies published, and we know that we know certainly that the patient receives the injection, and these are the few of the indication for the preterm labor and short cervical length. So there are certain evidences when in twin gestation, only twin gestation, you cannot give progesterone. But if it is associated with the shortened cervical length, less than 25 millimeters, detected at 18 to 23 weeks, you can supplement these women with vaginal macronized progesterone. So these progesterones are very effective. They act at the this one, but there is no rule of routine use of progestogens. One should remember, once the patient becomes pregnant, you need not supply these women with the progestogens, because you should know about the side effects of these progesterone unnecessary prescriptions. There can be mood swings, there can be hypersensitivity reaction, there can be dizziness, there can be increased risk of gestational diabetes, constipation, and importantly, you should monitor their liver function test. In some of the patient, you should be used in caution with cardiovascular disease and with the impaired liver function and cholestasis of pregnancy. So progestogen can lead to cholestasis, and this warns about the inadvertent prescription of progesterone in pregnancy. Only there are few indications where you can give progesterone, and that too there are varieties of progesterones are available. So you can prefer according to the indications and the guidelines. So you can go through the guidelines and find out the US FDA category B progesterone. So I just want to stop here, and the next session is on drugs and lactation. There are other things also I want to tell about the drugs is whenever you are prescribing the drugs, the dosage should be correct. You should explain the patient the correct dosage and side effects, and the neonatal side effects as well. The commonly used drugs are in lactations are relatively safe, and the dose received via milk is much small than the safe dose directly given. So most drugs are not concerned in breastfeeding. Most of the lactating mothers take very few medicines and very occasionally. So not advisable to suspend breastfeeding till the mother's medication. So how many drugs are excreted in breast milk, we should know. So, which is the drugs which are excreted, there is a possibility of altering the infant's intestinal flora. So always we say no, that what mother eats is it goes to baby through the breast milk. So monitor the infant for the gastrointestinal disturbance such as thrush and diarrhea. If they occur, you have to stop the drug and choose an alternative if necessary and continue the breastfeeding. So these are the compatible antibiotics which can be used for the breastfeeding, like amoxicillin, ampicillin, benzathine, penicillin. These are the penicillins mainly. So you can use compatibly, and now no data is available for these another other antibiotics which are like vancomycin, imipenem, then spectinomycin. These are the drugs which we don't know about. The paucity of data is still there. Now about you should avoid these antibiotics like chloramphenicol, ciprofloxacin, doxycycline, metronidazole, and nalidixic acid. These are to be avoided. Chloramphenicol, if the infant is less than 1 month, you have to monitor for side effects like hemolysis and jaundice. Theoretically, there is a risk of bone marrow depression, but it has never been reported. About doxycycline, there is a staining of, it is a tetracycline again. So single dose is probably safe. Metronidazole, the animal data is suggesting it is a carcinogenic. So in these women, if you are giving metronidazole, you have to help the mother to express and store it so that baby can be fed during that time. But I don't know, this metronidazole is relatively safe in antenatal patients and as well as postnatal patient. About the anticonvulsants and anti-epileptics in lactating mothers, the breastfed infants of mothers who are taking anticonvulsants sometimes develop the drowsiness. For mothers who need anticonvulsant, there is often little alternative. already the woman is on anti-convulsant. So it is essential that they take their medication, and it can be dangerous to change medicine suddenly. So breastfeeding is usually possible. The infant must be monitored. It helps to if the dose is kept as low as possible within the effective therapeutic range. So it is same as anti-epileptics when you are giving during antenatal period. So these are the compatible with breastfeeding. You have to monitor carbamazepine, diazepam, phenobarbital, phenytoin, and valproic acid. And you have to avoid ethosuximide for the infant side effects. So these are the few of the monitoring you should do whenever you are giving anti-epileptics. Antiviral drugs are compatible, like anti-herpes, they are compatible with breastfeeding. Nevirapine and zidovudine, with the exception of mild anemia with AZT. Prophylaxis and short-term effects of prophylaxis on infant are minimal, and serious early long-term toxicity in children secondary to in utero AZT exposure, if it occurs, is likely to be rare. So, drugs affecting coagulations are like low molecular weight heparin, desparin, prothymidine, and warfarin. They are compatible with breastfeeding, and protamine, there is no data available. Now, about the galactogogues, we know that these all natural acting galactogogues, they increase the milk secretion. And analgesics, antipyretics, non-steroidal anti-inflammatory drugs like we give in post-cesarean and other things, these are in if the patient is having rheumatic arthritis, if the woman is taking these drugs, which are the drugs which are compatible with the breastfeeding in occasional dosage, and you have to avoid the repeated dosage if possible. If the woman is taking codeine, you have to monitor the infant for the side effects like apnea, bradycardia, and cyanosis. And if the patient morphine, monitor for the again apnea, bradycardia, and cyanosis. All these codeine, morphine, and pethidine, they have side effects on the in the infants, so you have to monitor. Okay, and if I was telling about the analgesics, now these analgesics, paracetamol is the best on the safety profile for the breastfeeding. These are the main drugs we should not prescribe during pregnancy or during lactation. Anti-cancer drugs, then gold salts, lithium, chloramphenicol, atenolol, potassium iodide. These are the drugs which should not be prescribed in lactating women. These are the synthetic galactogogues one should know, like dopamine antagonists. They stimulate prolactin secretion. They cause galactorrhea. Metoclopramide as a galactogogue, you can give 10 milligram tablet and you can just follow this patient. If you give more of metoclopramide, there is extra pyramidal symptoms like tremors, bradykinesia, dystonic reaction, and depression. Domperidone is also, which is antiemetic, but it can be used as a galactogogue. The dose is 10 milligram 3 times a day, and it increases the milk production by 45% in 7 days of usage. Haloperidol also causes galactorrhea. Methyl dopa, which is antihypertensive, also it is not used as a galactogogue, but you should know that these are the drugs which causes galactorrhea. Theophylline, methyl dopa, haloperidol. These are the drugs which are causing. Now about the milk suppression, mechanism of action is dopamine. It acts on a dopamine as agonist, stimulate dopamine receptors and resulting in blocking of the release of prolactin. So these are the drugs which are anti-lactagogue, like levodopa, bromocriptine, estrogens, and androgens, and thiazide diuretics. These are the drugs. Now, one thing about the anaphylaxis. What is anaphylaxis? This is a serious allergic or hypersensitivity reaction that rapidly in onset and may cause mortality in pregnancy. It can be catastrophic for both and mother and fetus. Though the prevalence is only 0.05 to 2%, you should be always aware about this anaphylaxis. And there are retrospective studies. They have also found the rates up to 2.6 to 3% for 3 per 1 lakh women, but one maternal death due to some reaction to the drugs. It is very, very dangerous. What are the potential symptoms and signs of anaphylaxis? If any woman takes any injection and she complains of low backache or preterm labor, fetal distress, or uterine cramps, or patient complains of vulvar and vaginal itching, is it anaphylaxis? That question should come to your mind. So, what is the, you should have the risk assessment and risk reduction. So, one is you have to confirm the anaphylaxis, you have to find out what are the triggers, and then you have to avoid and you have to defer the medications. So you have to ask them the history of allergy. Whenever you are prescribing any woman, you should always ask allergy. For penicillin allergy, we know, but there are various other things you should also know that they can, allergen can increase allergic reactions. And there are in everywhere, these may not be available, like epinephrine auto injectors. And you have to train these women for this injections. Okay. So one most important thing is about the injection epinephrine. So this is an emergency injection we should keep for give epinephrine zero point 0.3 to zero point 0.5 milligram, preferably in the mid of the thigh. It can be repeated every 55 to 15 minutes as needed, and most patients respond to 1, 2, or 3 dosage. So this is very life-saving drug we should keep in the emergency drug. The you should also know about the contraindications and drug interactions. The patients with pheochromocytoma are at risk of excessive autonomic stimulation from adrenergic vasopressors. So patients receiving monoamine oxide inhibitors are extremely sensitive to vasopressors and therefore require much lower dose. So whenever you are giving adrenaline or epinephrine, you should be very careful about these things. This is in nutshell the commonly used drugs that should be avoided in pregnancy and what are the safer alternatives. So if you take the analgesics, you should avoid non-steroidal anti-inflammatory drugs. We have associated problems like increased spontaneous abortion and cardiac defects in fetus. The alternative drugs are paracetamol and opiates. If you see the antibiotics, you avoid trimethoprims and aminoglycosides. They are folate inhibitors. They cause structural defects like left palate. So alternatively, you can use penicillin and cephalosporins. Anticoagulants, we know warfarin, first and third trimester, they cause embryopathy, central nervous system defects, hemorrhage, stillbirth, and spontaneous abortion and prematurity. Alternatively, we have fractionated or low molecular weight heparin. In anticonvulsants, avoid sodium valproate, phenytoin. Associated problems, major is neural tube defect and minor congenital abnormalities, growth restriction, and hepatotoxicity. And you can use the newer anti-epileptics like lamotrigine. Cardiovascular drugs, ACE inhibitors are contraindicated and amiodarone is also contraindicated. They lead to stillbirth, renal agenesis, cardiac arrhythmias, and growth restriction. So alternative drugs here you can use digoxin. Hypoglycemic sulfonylureas are not used and they lead to multiple organ malformation including central nervous system, gastrointestinal and cardiovascular. So insulin is the first line of drug used in diabetes. And other drugs which are avoided are cytotoxic, retinoids, statins, and thalidomide. Never use. There are no alternative for that, but never use these drugs because they lead to various congenital defects like spontaneous abortions and limb defects and abnormality of major organs and central nervous system. So what we must learn are drugs are not always safe. Time, duration, and dosage, routes, administration, etc. have different impact, especially when used during pregnancy. The objective of this session is rational use of drug, and writing a prescription is an art and science. So doctor need to keep in mind that there are many essential, sometimes legal requirements that are mandated in practitioner's prescriptions. So any prescription format should have a doctor's name, degree, state medical registration number, address, their email ID, patients, and name of the medicine should be in capital letters, and it should have a strength, dosage, instruction, duration, and total quantity. And usually you never prescribe in a trade name. You should always write a generic name, and you have to always write the date dispensed. And even you can see in the down that there is name of the pharmacy, postal address, everything should be written in complete. So this is a complete prescription format you should have. So to know the maximize of patient safety, always write legibly, always space out words and numbers, and avoid the confusion, and always complete the medication orders, avoid abbreviation, right? Whenever doubt, you also verify. So always I tell my postgraduate, ask the last menstrual period. First trimester use A and B category drugs. Category C may be used after first trimester. Category D should be avoided unless benefit outweighs the risk. Don't use the category X drugs unless pregnancy needs to be terminated. So this is my mail ID, and I invite, because 2 hours was an exhaustive talk. So any queries of any drugs, you can mail me, I can answer them. These are the various drugs in nutshell. All the drugs I have given in asthma, what medication is to be preferred, infections, and depression, right from like ABCD, it is arranged. And you can have the first line and second line of drugs. So I will quickly wind up. And these are the commonly used drugs which I have again compiled and given. So there are various website also to visit. We had handy sims and memes. Now Google is at your hand, but whenever Google is there, but you should follow the guidelines. And what guidelines? Foxy has got its guideline, international guidelines are there, ACOG guidelines are there, RCOG guidelines are there. Whenever you are prescribing, there should be some support, that you are writing in a proper way and for the proper disease. That's why we call it as a rational drug use, rationality of the use of drugs, and rational prescription, what we always call. So what is the rational prescription? Is for the rational reason, um, and rational drug in the right dose and the right um, duration. So duration is also important, right dose is also important, and right drug is also important. And thank you for the patient hearing. I think it was very exhaustive talk of mine, and hope
Madam, can you put up your mail address, madam, so that there are some
yeah,
people.
because it is not possible now. Okay, I'll put up.
So that they can put the queries to madam in her
Yeah,
mail address and madam will answer. And
yeah,
anybody who
that.
wants the particular slides, madam will be sending it to you.
Yeah, I will share my slide also. Can you take the last slide had, no? I think
The 3 slides before it was there, madam.
I will share it again. Yeah. Now you can see my slides.
We can see your slides, ma'am. Can you move it to the mail address?
Yeah.
Yeah, there it is.
So this is my
Participants,
mail
please
address.
note. Yeah.
Because already it is 4:10, so I don't think there is some time. And the drugs and dosages are all available, but the rationale of using the drugs and the right dosage you should know. Any queries, you can just mail me. I will be able to answer
Ma'am, your
you.
mail address, please, ma'am. At least for a minute, we'll keep so that they can note it down.
I don't know. Again, it has gone. Eh?
Yes, ma'am, it's gone. Yeah, it's in the other slide now. I think you have to go
Anam?
down now.
Yeah, it has
Yeah,
gone.
yeah,
Again,
before. Two slides before. Yeah, same. Yeah, it's there. Please note down madam's mail address. Please put the queries to her. Madam will be
directly, I
answering.
will be able to answer your queries there and there only. I will immediately answer. I'll drink some water.
Yes, ma'am.
So thank you, Charmila, and thank you,
Thank you.
Priyankur, for this one.
Yes.
This was a very exhaustive. I think I did some injustice for not covering many things, but
Madam, it was a very comprehensive talk, and this is an exhaustive topic, but you've covered as much as possible, and I
as
think
much as
that
possible.
that's of much use to many of the PGs here. So
Yeah.
please put your questions to Madam. Madam is not feeling well
can-
also. She, in spite of that, she has come for us. So please use her, and you can put your queries to Madam's mail address, and she will answer it. And any slides you want, I've seen some questions on fever in pregnancy and all that. Madam will be putting the answers. The mail address is there. Huh? Please note it down.
Yeah.
THOBBI. There's a question from the panelists. Please note Madam's mail address, please.
See, the drug of choice in epilepsy, we have given that newer epileptic drugs have come, and it is safe to apply diclofenac gel for backache. It is very safe, and we can give you the recorded version. I can share you the this one, whatever slides you want. That's what.
Okay. Please send the query to Madam. Madam will be sending it. Thank you so much, ma'am. It was very exhaustive, comprehensive, and this is what you can do in this period of time, it's a short period of time. But you have done great justice to the topic. We enjoyed it so much. Thank you so much, ma'am.
Thank you. There are few questions, Charmila. Dosage of calcium tablet in pregnancy and lactation. See, they have written 500 milligram or 1 gram. See, for prevention of whenever we are giving preeclampsia, we tell that 2 gram per day. But otherwise, it is 1200 grams. We can 1200 milligrams. It is per day. You can safely take, and it doesn't cause any renal stones if your intake of water and everything is good. There are no renal stone. There is no development of renal stone as such. There are various calcium salts are available. So calcium citrate myeloate is one of the tablet you can prescribe, which has got a least chance of renal stones as of what is studied. Then one more question, Methargin 2 requires cold storage? Yes, it is. So these are the questions.
So along with your oxytocin, you have to keep your methogen also in the fridge before you take it out for your peer management. Yeah. Thank you so much, ma'am. Thank you.
Yeah, thank you very much, Armila, and being with us, because you left for 2 hours and you are such a dedicated this one.
It was a good talk, madam. Thank you so much. I enjoyed it. I'd like to thank Satish of Alembic for the arrangements. Thank you, Satish. Thank you so much.
Thank you very much. Thank you very much.
Okay. I'd like to thank Dr. Ashwat also for the organization, and Dr. Priyank. Thank you, ma'am. Thank you so much.
Thank you very much. Thank you.
Okay, ma'am. Thank you.
I'll end it now, ma'am.
Wait. Satish, 1 minute. I'll just not. I'm just closing it. Yeah. I just want one screenshot, Satish.
So do you want to start screen sharing?
Yeah, I'll start screen sharing.